what needs to be done? A lot. No, innovation is of course key, and especially for patients, and we need to probably involve more patient and patient organization in the early development phase already to think about and to be more pragmatic and fast, maybe. And one thing to think about is also our main competitor in innovation is the bacteria itself, because they innovate constantly in resisting to antibiotics. So we need to be, and if we think about only of new antibiotics, we will be always slower. So that's why we need a broader scope of innovation. Antibiotics, new antibiotics is a strong pillar, of course, but also diagnostics, faster identification of the bug, faster knowing the sensitivity to drugs, and also in prevention. IPC, infection prevention control, is key and is important, is a strong pillar of prevention, but not only. And today, guidelines, recommendation, policies on infection prevention are more or less limited to wash, so water, sanitation, and hygiene. Maybe sometimes a bit of vaccination, but there is more to be done. For example, at BEAM Alliance, which is an association of biotech companies, mainly small and startups in Europe, innovating around AMR, they focus on the three topics, so new drugs, and not only antibiotics, but also alternatives like phages. You have a lot is done on diagnostics, and recently there is a group on prevention where we are part of course, as OM Pharma. So it's a key. And to go more specifically on prevention, this is a very important topic because first of all, it needs prevention, so it needs all the stages. So better avoid the infection first. That's probably the most efficient way to use less antibiotics, and not only use less, but avoid misuse, because a lot of antibiotics are still prescribed where it should not be, and overuse. So there is also too much use. So if we really want to decrease the use of antibiotics, we need to insist on prevention methods or strategies. And so I talked about IPC, so infection prevention control, and WASH. This is quite well implemented, or more or less well implemented in the hospital setting. Maybe there are differences between hospitals, between countries, and between regions of the world, clear. But in the community, that's where the gap is in terms of infection prevention control and antimicrobial stewardship. When we know that 80% of the antibiotics are prescribed in the community at all, and 80% of these prescribed antibiotics are for simple infections like respiratory or urinary infections. There is a big gap there in terms of what we can do. So a lot to do in the community, in the hospital still, and to implement more preventive approaches.
Can I ask you, you say that in the hospital settings it's well implemented. Do you think that the hospitals are doing everything they can to prevent infections?
I'm not sure if they do everything they can. At least they try to implement most as they can the strategies for cleaning, for disinfection, washing, and so on. Always can be done more, of course.
Can I build up on what you've mentioned so far? First of all, I fully agree with you. On the other side, I think something that was already mentioned by a few of the questions here is important to mention again, that this type of prevention and so on is very different from the eyes of a patient with a chronic condition. So we say that we have to be careful and we have to, have the antibiotics only when it's absolutely necessary and so on. But the reality for people with that are immunocompromised, people that are currently on some type of cancer treatment, and many, many others, unfortunately, is very different. For example, I have been to the hospital maybe 7 times in the last month. Each of these goings to the hospital is a risk. And there are many of us chronic patients that cannot afford this type of delay or waiting for the specific end of the moment to go to the hospital. No, for us, the smallest thing, you have to go to the hospital immediately. So every time, that is definitely a risk. And then the other thing that I wanted to mention is that the antibiotics use is again quite different for patients with chronic conditions. What I'm trying to say that even something that you mentioned as simple as a urinary tract infection, in many cases when it's I hate saying healthy person, but let's say healthier person than a patient with a chronic condition. In that regard, I think there are quite a few different ways that might be taken. However, when it is a person that is struggling with a chronic condition, you don't have that type of luxury. And in many cases, you need to start an antibiotic immediately just to relieve the symptoms, and then wait for the antibiogram for 3 days to come out, and then hopefully get the right antibiotic if the first one wasn't the correct one already. So things are much more complicated when it comes to patients with chronic conditions, and I really believe that what was mentioned earlier by both of us, earlier diagnostics and more reliable diagnostics, is something that is a first step that is necessary for better treatment of all people and patients with chronic conditions. Thank you.
Fully agree. That's key. And I fully agree. I can only agree that a patient with chronic condition is not the same as me or other so-called healthy patients. Yeah.
So we have 2 quick questions. So one from Eden and then Constantina right away, if you can pass on the microphone.
Hi everyone, I'll start first. My name is Aiden Kaal and I'm here on behalf of the EPF Youth Group as a member. And I figured I'd just share some perspective on what you were asking regarding hospitals and how this actually goes about, because I'm also a medical student, so I can give a little bit of insight. Now I'm Dutch, so I can't speak on behalf of every other country besides the Netherlands. But one of the key things that, to give an idea, I'll start with the acute setting. If a patient would come in with an infection, what they have in the Netherlands is they have a very constructive plan that they follow. We call certain guidelines, so as to say, where this patient is immediately drawn some blood of before the antibiotics are given, and this blood is then used to assess immediately in the lab what type of bacteria would be at play, or if it even is a bacteria. And then afterwards they would start on a more specified antimicrobial medicine specifically targeting that said bacteria. Thing is though, here's where the big trouble comes in. There's a gap in between that moment of not knowing what it is and still having to keep the patient safe from any further damage. So what we do is we put a broad spectrum antibiotic just for control so that we ensure everything goes smooth, so as to say, until we can then be more specific. But here's the trouble. You have 3 different things where things can go wrong. 1, the blood might not be taken properly, and you need to do it again. And now you've already given antibiotics, so you will never truly get a proper grasp. 2, there's a time problem, because depending on what type of infection that might be, if it's somewhat rare or exotic, there isn't really much of a guideline implemented for that, because that involves expertise, and that expertise involves having a lot of different areas. And finally, the last thing is the actual implementation, because then there's the choice of having to do it either via what we call intravenous, or just oral administration. And we've recently been doing research to see which one's more effective. We found out oral overall is easier, but intravenous is only necessary in like very specific circumstances. There you go.
Thank you.
Thank you very much.
Okay, super quick question. One sentence, please.
Yeah.
Konstantina.
You mentioned that the hospitals are doing everything they can, but this might be in North or Central Europe that the money exists. But in Greece, that I'm from, money don't exist. So the hospitals can be organized. They can even sanitize anything. So we have the higher, of course, AMR cases, but it's another topic. But also we have the higher hospitalized infections, which is 10% than the average of the EU, that is 5 to 6%. And before Mr. Danilo said that you're communicating with member states, but are you sure that they are implementing? Because Greece has said that they will implement anything, but they haven't done anything. So, like, and still we're #1 in all of the severe cases and in all like hospitalized infections or AMR cases or whatever, misuse of drugs, of antibiotics, and misuse of anything. So like the only thing that we did was to prescribe antibiotics because 2 years ago you could go to the pharmacy and just take it with no prescription, which is like, yeah.
Okay. One last question, and then we move on to the next speaker.
Hi, Melanie Hosta, implementation scientist from the University of Antwerp. Sorry, throat is scratchy. I just wanted to comment on the fact around diagnostics, because I understand that right now, especially from a member state perspective, there is a lot of pressure, I think, for rapid diagnostics to be placed in acute settings. And I just wanted to stress that whilst understanding some of the ambiguity that comes around point-of-care testing, we should be focusing more, I think, around antimicrobial stewardship. So not just focusing on diagnostics as a cure or a one-size-fits-all to care for patients, but looking at different types of interventions that can be tailored to specific contexts, especially because each context works differently. So I just want to caution with the use and this pressure on point-of-care testing and diagnostics, because it can be a difficult arena, especially when you're considering behavior change. When the moment a patient goes into an acute setting, it's not just a test result that will determine whether or not a patient walks out with an antibiotics. It's also dependent on clinical assessments. It's dependent on a sociocultural perspective as well as to how the clinician prescribes. So just throwing caution out there about this emphasis around diagnostics. Thank you.
Thank you. And I think, Danilo, in the initiatives that WHO has done, you have a comprehensive approach. It's a toolbox, basically. There are many tools in the box, and obviously we need to look at comprehensive solutions. Which brings me actually to the next speaker, Ulrika. I think there are still some research gaps. I mean, we were talking about behavioral science, for example, and more generally, we know a lot about AMR, but there's still some things that we don't know. So perhaps you can tell us a little bit from your perspective, what are 2-3 key research gaps? And EPF is actually part of a project called OHAMR, which aims also to bring researchers closer to policy and closer to communities. So if you can tell us a little bit about that and how you work within this project.
Yeah, thank you. No, it's not on. Another one? Hello? Yeah, this one's on. Brilliant. Yeah, so I'm Ulrika Donhammar. I'm from the Swedish Research Council, but I'm here to represent this project that Claudia mentioned, the One Health AMR partnership, which is it's a 10-year collaboration of more than 30 countries that essentially pool their national research funding money in AMR together to explore AMR from more perspectives and try and fill the knowledge gaps that we still have. Because, I mean, AMR is a massive issue, as you've understood. There are so many perspectives. There's the health, the veterinary perspective that was brought up a little bit earlier, the environment, there's everything from microbiology to how do you run a hospital, how do you run a healthcare system. So there's so many perspectives, so much knowledge needed to navigate through this super complex issue. And it's also very interesting to listen to the colleagues here on stage and to all the questions, because it just highlights all the things that we still need to address. And one thing that I wanted to bring up here today, and what really brings me here actually with a very open mind, is that I think one key gap that we have is this experience of AMR. We know a lot about AMR in the hospital. A resistant infection, or an infection caused by resistant organisms, causes a longer hospital stay. There's a higher risk for complications and other problems. We know that from the sort of clinical perspective. But what is AMR to the person that hosts it in their body? What does AMR add to your cancer, to your kidney disease, to your diabetes, to your musculoskeletal condition, whichever condition or disease you have? What does AMR add to that? What is the experience? Because I think we don't really know that. There's been a lot of talk about it here today. Last week at a high-level meeting on AMR, this was also very, very hot topic. So this is really coming. And I think this can be a key to moving forward as well, because AMR has been a big topic for decades, and we know a lot, and there's a lot of political momentum and all that. But as every big complex issue, we struggle with keeping the momentum going. And I think this lived experience, or the patient experiences, could really bring fresh perspectives in here, and new energy and new sort of life to this issue. And moving on to my last point, I think that those voices and those characteristics could lead on to also renewed advocacy for access to effective antibiotics, to access to new antibiotics, so research into novel treatment strategies, novel drugs, or access to old existing antibiotics, but they need to be available on time. Access to diagnostics, like we just talked about, all the rest of it, to keep this issue on the political agenda, on the funding agenda, on the healthcare systems agenda, because AMR is an issue that can sort of make and break nearly all of our modern healthcare systems, and nearly all of our health as well, because it affects so many different parts of it. We know that, sort of, but we need to pin down that knowledge, I think, because I think that can unlock a few more steps into funding and momentum here. Thanks.
Thank you very much. And I think that links very well to the last intervention, Joe.
Yes.
So Shinogi is very active in the infectious diseases space. Ulrika was just mentioning access, so I think we'll start with this question. From your perspective, what are 2-3 priority actions to ensure that all patients across Europe have access to the right antimicrobial at the right time? And perhaps we can start with this question.
Sure. Good afternoon, everyone. It's really nice to be here, and thank you, EPF, for providing the platform for such an urgent and important discussion, actually, particularly timely, I think, with the legislation that's coming through Brussels at the moment. So thank you very much. I'm Jo Taylor. I work, as Claudia says, for Shionogi. We're a Japanese pharmaceutical company. We are the best kept secret in infectious diseases, so I'm expecting that not many people have heard of us, but we've actually been in existence for over 145 years and working in infectious diseases, or specifically reserve antibiotics, for 60 years, so a long time in this space. I'd say the priority actions from our perspective is that firstly, we need sustainable, predictable access models, as you said, Claudia. We need to introduce sustainable models to attract pharmaceutical companies back into researching and developing new antibiotics, because we have a dwindling pipeline of antibiotics, and at the moment resistance is rising faster than new antibiotics are being developed. So that's a crisis, really, in development of antibiotics. I'm pleased to say that we, despite the fact that the marketplace, as companies would perceive it, is unattractive, because when you think about how reserve antibiotics are and should be used, actually, along with good stewardship guidelines, is what you want to do is to reserve them until they're absolutely necessary and then use them sparingly for fear of developing resistance even further. But as a company, if you're looking at therapeutic areas to research and develop in, that isn't a particularly attractive commercial model. So that's why we need to look at other financing, really, because you wouldn't necessarily expect a pharmaceutical company to be calling for more pharmaceutical companies to come into a space to have competition, but actually that's what we want. Now, we need this sustainable financing, and at Shionogi, we're proud to be one of only 3 companies that actually participated in something called the NHS England subscription model, and it was a pilot, or you might have heard it called the Netflix scheme. The scheme is being made permanent next April and will be in place from then on. Now, the financial model is a world first because what it actually does is it delinks revenue from sales volume of antibiotics by giving companies an annual fee, which, like a Netflix subscription, in theory would enable the health system to use as much and have as much access to a reserve antibiotic as they want to. Now, the check in the system is that both the company and the NHS are signed up to good stewardship. So it's in neither's interest to increase prescribing because it's an annual fee. And therefore the model works because all parties, it ensures patients have access to the right drug at the right time. Health systems have an unlimited supply at a predictable and sustainable cost. And companies have predictable demand and revenue certainty, and companies like certainty, which in turn we hope will bring more R&D and companies back into AMR. Now, we recognise that subscription model, obviously what is in the UK, it doesn't necessarily work for all member states, it doesn't work for all market conditions, owing to variations in the health service, epidemiology, level of prescribing. Which is why our position as a company is to look at any pull incentives seriously on its own merits and its suitability for that country. We're participants in the Swedish revenue guarantee scheme, which is kind of more of an access model, but does guarantee access for patients to antibiotics. So we very much welcome at the moment, I mentioned the legislation, we welcome the important step that Europe has taken in introducing something called a transfer exclusivity voucher in the pharmaceutical reform as a recognition, really, of the need to reward antimicrobial innovation, and we now need to build on it. Sustainable funding is essential for the future of antibiotics and for all patients who rely on them. The other 2, and I'll be super quick, is we also, I think a priority is to strengthen system readiness and patient pathways and very much include the patient voice and consultation with patients throughout every step of the pathway. Thank you.
Thank you. There's a session tomorrow about innovative incentive models. Of course, if any of the speakers want to react. No? Okay. There's, just to finish, there's a session tomorrow about innovative pricing models and how to ensure access, and I think you mentioned some things that happen at national level. We are also looking at how to replicate that at European level and to ensure that the EU has more power in this area. But I will turn to the floor for very quick reactions before we move to the breakout groups.
Okay, so I fully agree with what you say, because this is one of the big reasons why new antibiotics don't survive very long. If we take the example of Greece, so if you have an array of antibiotics to your disposal that you can use, and you have an unknown bacteria, just push in the hardest, the newest, the strongest antibiotic as first choice, instead of first trying a penicillin. If it would be a solution, we use the last resort first, and that also counts for a lot of hospital use. If you have an acute question, you come with the top answer because that might solve the problem, but you're causing a new problem. And even for the Netherlands, you will only take blood if you suspect septicemia, otherwise don't need to take blood. Then you won't find anything. So application, use is extremely important. And indeed, If we can find a way so that new antibiotics are reimbursed much higher if they are used correctly, that would solve part of the problem. Thank you.
Okay. Quick comment.
Okay, thank you. And I wanted to understand why none of you have been talking about food and collaboration with patient organizations. Background is 2 years ago, I was resistant for a bacteria, so almost killed me. Took about 7 days for the doctors to actually figure out how to give me the right antibiotic. But one of the things that I learned afterwards was actually food has a very high antibiotic in it. So the food that we are eating, we have to be aware of that. That is collaboration with patient organization to knowledge that there is something you can do yourself. It's not about getting new antibiotic all the time also, and new systems and new methodologies. It's also what can we do for ourselves.
Thank you. I think indeed we've seen a lot of different solutions. I mean, obviously we're talking about access to new antimicrobials. You mentioned access to existing antimicrobials, which is also a big issue across Europe. So there are a variety of issues in the AMR landscape, and that means there are a variety of solutions as well. So we will move now to the breakout groups, because I want to ensure that you have enough time and you have a lot of input to share. So each table has a theme, as I mentioned. Here is patient-driven innovation. You have a small prompt here, which is just a short framing, really, of the discussion with some suggested questions that can help you guide your discussion. And what I would like you to do is to identify 2-3 concrete actions that, as patient community, we could implement and we could decide to take on. So to make it very concrete, first of all, think about what. So what is the action? Describe the action. How? So how to carry it out? What are potential barriers and potential opportunities? And with whom? So with whom could we partner in order to make it happen? Related to the theme of your table. And then we'll regroup after that. I would like to keep 10 to 15 minutes at the end so that we can regroup, we can exchange ideas, potential actions, and hear the results of your reflections. So think also of a rapporteur for each table who can report back. And our speakers will rotate among the tables and help you with the discussions. 15 minutes.
I saw that you gave the microphone on stage for the Q&A. There's 2 microphones, 2 ladies with 2 microphones.
About measurement, and how can we measure that? So
now we are fighting, for example, a clarification where
Keep the book up at this stage.
There is another one on governance.
I would love to. Yeah.
huge amount. 2 minutes. Okay, I'm sorry, I'm going to have to interrupt you. The time is up. We need to reconvene. I want to hear about your actions. Okay, thank you very much. I'm sorry, I'm going to have to interrupt you. I can imagine you have very, very fruitful conversations. I'm sure you can continue them at the cocktail later today. All right. We will start. Yeah, do I have a little bell? Thank you. All right, so we will start with the reporting back. I can imagine you had some very good conversations. So perhaps we start with the tables around communication and awareness. Do you have a rapporteur for the two tables, I believe? Please volunteer. We have 1 minute per table. Yeah.
So on the clear communication and what does an impactful awareness campaign look like? So we said that in order for it to be impactful, it has to be in already existing and well-known channels. So using already existing channels for communication with clearly targeted information for the different target groups. Meaning for elderly people, there is specifically targeted information for patients and so on for all the different target groups. Then we have collaboration between trustworthy sources. So this is where the whole trust comes in. I really believe that what we've already heard from ECDC, statistics and so on are just, you can't really fight that. It's a statistic. So that's why we're saying that a collaboration between trustworthy sources is key. And then we have also awareness campaigns, including videos of influencers or resonated representatives that include patient testimonials, because we think that the best way to understand something is by example. I think I... Good? Yeah.
Thank you very much. The next table on communication and awareness. I think it's...
Yeah, not enough time to write it down, so I will try to formulate. We spoke about the fact that patients are in increased need of information about why the antibiotic has been prescribed, how to take it and for how long, because today probably physicians don't have always enough time to do it. The consultation time gets, let's say, more and more restricted. So if you direct target the patient via, for example, consultation room, leaflets, social media, webinars, then they may be better aware and maybe they can also feel stronger in speaking with the physician about why have I got antibiotics and what is maybe the pros and the cons and etc.
Thank you. Very concrete suggestion. Shall we move on to evidence for policy making? Sorry, Bianca, I'm going, making you go back and forth.
El Presidente. Well, I was appointed the chair and now also rapporteur of this, and president, thank you. Very active group. It's exactly, it's impossible to summarize a very rich discussion, but I think if I need to sum it up, there was some concern about not reaching marginalized patient groups, but that the most effective examples of successful campaigns are bottom-up. We've seen now for the past number of years there's a very strong high-level commitment which doesn't really dribble down into actual action and engagement, unfortunately. Am I missing anything? Yeah.
That we have to have a place around the table. As a patient organizations, that's very important. So we can move all the mountains that we have, and we can do it from bottom up, but we need around the table so we have the knowledge around what is happening. So I think that was it.
Thank you. Next table on evidence.
Okay, we had a very rich discussion too, and it's her idea, totally super good idea, because we were reflecting on the fact that the patients really lack a lot of information in the experience of AMR, like how many patients really get a result that they had a resistant infection. Blah, blah. So one of the actions that we were discussing was an action that actually took place with patient organizations in Slovakia, and it was around asking the right questions to the doctor, empowering individual patients. So the patient organization gives all the training and cards for the individual patients to go and ask the right questions, like the simple, why am I getting an antibiotic? Do I have a resistant bacteria? This type of questions that empower them to know and to then give their feedback to evidence.
Thank you. Very concrete example as well. Next, maybe governance and support to implementation of national action plans.
Hello. I think our one builds really nicely on your example, because we said the biggest support and governance issue is implementation, I think. And for that, I think that patients need to ask the right questions, but to healthcare professionals who need to be involved, because they're the ones prescribing the antibiotics at the end of the day. So we said that we need to create feedback loops that involve healthcare professionals and patients, focusing on shared decision making, giving patients the right level of education, and involving healthcare professionals from all sectors, because that's the one cross-cutting issue that's very important.
Great. Where is the other table on governance? The empty one, okay, so nobody there. We had the discussion before, so that's great. Okay, so then patient-driven innovation.
We didn't really discuss the report.
Okay, Elena.
Yes, so we thought, how can we support research and development of new products? Because we are aware that we need innovation, we need new drugs. And then these persons from Portugal said, well, you know what, we need to convince the general public to participate into clinical trials? Because it's always very demanding, and it's not easy to reach the general public and convince them about the benefits of participating into clinical trials. But we know how to do it. From the patient's voice, we know the language to use, so we can not convince them, but it's just to detail what you will gain if you are included in this research for this new innovative product. So we will use these tools that we have as patient group, and it's to use the perfect language to spread out the benefits of these clinical trials, because we think it's fundamental and crucial for science.
Thank you. The other table on patient.
Thank you. More or less is the same. We also talk about patient engagement as disruption and innovative patient-driven innovation. And we were talking about the importance of the patient engagement from the very beginning in the research and the development of new antibiotics, for example. So we have some barriers and opportunities like statistics, information, or training for patient organization is also important. And here the role that patient organization can play is key. And we talk also about the importance of umbrella organization, because sometimes it's not clear if the government are willing to talk with patient organization, who are exactly the patient organization to be engaged. So umbrella key important role here. And we start talking about awareness, not only about innovation. So I use the example of the collaboration of my umbrella organization in Spain with the government, with the PRAM, that is the program for antimicrobial resistance, and we have developed together a guideline, publication and videos focusing on chronic patient and patient organizations to deal with this situation. And for us it's quite innovative, because the government was not putting this on the focus, and they were working with hospitals and so on. So they have swept, and they are now looking. We are presenting in the Ministry of Health next month. So for us, this is also innovative. And we have some example here.
About awareness raising, really, that where I'm from, which is in Wales, local GPs, all of them have kind of awareness raising campaigns. When you sit in the surgery, there are a lot of screens, and it talks about antibiotics, it talks about vaccinations, and you get asked that, and you get text messages as well. So if you're in a high-risk group, you'll get a text message, but it's around raising that awareness and giving you the information that you actually need. So that's about, it's really important that you have that information to know how you can make changes, really. Okay.
It's great you have all those very concrete examples. I think we're taking good notes and using them definitely as best practices. We can clap. So. And the last tables, I believe, on antimicrobial stewardship. Yes.
Okay, shall I report back? We had a really interesting conversation as well, spanning from across different contexts, because stewardship needs to be placed in the right context in order to be efficient. So we talked about, in certain contexts, we had a Greek representative who said we have to talk about the basics. Use the right number of pills for the right number of days. It's like really start with the basics. Whereas in other contexts, we had an example from France where it was really feasible to take away the demand for a prescription in uncomplicated urinary tract infections in women, not pregnant, and sort of the standard UTI in women, and see a really good result when you opened up and let the patients themselves take the responsibility for antibiotic use in that particular context. That can also work. We had a nurse's example of where nurses see patients much more than what doctors see patients in hospitals. So nurses can pick up on changes, talk to patients. Can you switch to an oral formulation instead of an intravenous formulation? So picking up knowledge from many more sources, and that can be the keys to stewardship. And what else did we say? So I guess to pull it together is like identify the niche, the points where you can involve other agents in taking responsibility, really.
Yeah, please. 2 minutes, perfect.
Oh my God. So I have to rush up because I have to explain. So we took an example where we went all the way. So the example is biopsies in prostate cancer. I'm from prostate cancer, so we know what it is. You have two possibilities, transrectal or transperineal. For the urologist, transrectal looks more easy. What is the outcome of both of these techniques? They have similar results. The transperineal has slightly better results, and this is looking on the diagnostic aspects. What is the other element? This is that in transrectal, as you can imagine, you have a higher chance of infection. So in transrectal, antibiotics are used, and that is one of the reasons why we disadvise, I'm in the guidelines committee of EAU, so the transrectal path is disadvised in favor of the transperineal. The transrectal is even no longer in the guidelines. And as patients, we've pushed that, so that is where we come. So the other one is, why isn't it then implemented 100%? So there is a resistance to change from those who did transrectal for 25 years. They need retraining. The only group that is easy to retrain are the nurses who do biopsies in UK, because you just say, either you do it transperineal or you don't do it anymore. So you can force them, you cannot force the doctor. So this is the issue for implementation. We are not there yet. So the reason why this has to happen is AMS, because using antibiotics at biopsies increases the chance of creating resistance of macrobiotics, because you use them each time, and not in transperineal, no antibiotics are used. And because the results are the same, you can indeed say in guidelines, and that is the path how you do it, in guidelines only transperineal is advised from now on. And this happened 2 years ago, but implementation takes its time. What else needs to be said is, it is that awareness is needed, so patients need to know, the doctors need to know, and that is a slow path. It is not because it's in the guidelines that it's done. And that is for all things that are in guidelines. They see them as guide, not as have to do. Thank you.
Thank you very much. I'm sorry, we don't have any more time for questions. Thank you very much for a really productive session. I hope you found it interesting and it gave you some food for thought also for engagement in the topic. And of course, we'll continue the conversations.
Claudia, we will give the present to everyone, so if they can just raise their hand.
There's a small present for our speakers, if you can come back. Yes, you can go to see. Yeah, she's coming to us.
I was thinking of stealing one otherwise.
You get one.
I can just go one under the bridge. I think that went very well.
Hi, good to see you guys. Better tomorrow, I guess, right? Do you want us up already beginning?
I think that's a good question. I think, yeah, you can just, if you can be on so that we save time, I think.
Copenhagen, the Life Science Summit. I think you were there as well. Yeah, yeah, it's a virtual thing, so.
You attended online?
No, but I thought it was not only online, but also.
I have over there, and then I'm missing Charlotte is here, so I have a lot of
People are still coming in. It's already 7 past. Should we make a start? Yeah? Hi everyone, if you could please take your seats as quickly as possible.
Yes.
Please take your seats. We are ready to start the next and final session.
Nico, Stéphane, Charlotte, and myself.
We have a public announcement. Did anyone lose their telephone?
Amongst many other things, yes.
There is a phone that we have found, and it's at the registration desk. So if you've lost your mobile phone, please go to the registration desk to collect it. So welcome back, everyone. Thank you for being here with us today. And we'd like to also thank you, our contributors and participants, for their insights and input into the workshops. It was really great. We have some really bright minds in the room, for sure. So something we're very excited to share with you are the preliminary results of the EPF Barometer on Patient Involvement in National Health Policy. So I hand over to my colleague Claudia Luati and her panel to hear what's happening on the ground from the national level in the fireside chat right now. To you, Claudia.
Thank you very much, Ruth, and welcome back, everybody. I'm sorry you don't really have a break in between the intense workshops and this session, but hopefully you can still follow a little bit, and we can keep a little bit of time at the end for questions. So I think I'm here with my fellow panelists. I think I will just let them introduce themselves super briefly. One sentence. Stefan, you want to go first?
Yes, wonderful. Good to see you all and meet you all. My name is Stefan Eichwalder. I come from the Austrian Ministry of Health, amongst many other things. So it's labor, but as you said, keep it swift. So I will stick to health. Work there as the Deputy Director General responsible for the Health Systems Division. And yeah, glad to be here.
Charlotte.
So, good evening, I'm Charlotte Roffian. I work for a French alliance of patient and healthcare users organization called France Asso Santé, and I've been working for them for about 15 years, and I'm an advisor on European issues.
Good afternoon, Nikos Dedes. I'm the chair of the Association of People Living with HIV in Greece, and through that we are members of the umbrella organization of all conditions in Greece, the Greek Patients Association, and I'm also a member of the board of the European Patients Forum.
Thank you. So the way we're going to go about this session, first of all, we're going to talk a little bit about an EPF initiative that is close to our heart, which is the Barometer on Patient Involvement in National Health Policy. And then afterwards we'll have, and I will do that also with the help of the national coalitions that are here on stage and in the room. And then afterwards we'll have a bit of a discussion more concretely with the panelists on the results and how to move forward with patient involvement. So at EPF, as you all very well know, our core mission is not just to talk about patient involvement, but also to make it happen in practice and to give the tools to our community to help them to get involved in the discussions that affect them. So in the past 20 years as EPF, we've collected a lot of very good examples of patient involvement across projects, across policy areas. We have a very good overview of what is happening at EU level, the opportunities, but also the gaps, of course. But we're missing a little bit this broader European perspective. And we know that our members have that experience and that expertise. So why is a barometer necessary? Because we want to map the level of involvement of patient organizations across policy areas. We want to measure also patient involvement because we don't have a lot of tools at the moment. We want to identify good practices as well as bad practices, being able to compare and contrast the experiences across countries. And we want also to examine the barriers and what we need to do in order to make that involvement possible. So why this barometer? We want also to provide a tool to support more structural patient involvement and ultimately more patient-centered healthcare systems. Next slide, please. So we want to thank our national coalitions who are making this possible. We are really basing this exercise entirely on their expertise, and they're the ones that are providing the examples at national level as well as the best practices and telling us really how it happens. So this is apologies for the formatting. We have 26 organizations that are participating in this initiative, coming from 22 regions or countries across Europe. So we are hoping that this barometer will give a broader perspective and experiences from different regions across Europe. And you see the map here. I think we have a very good coverage, which reflects, of course, our national coalitions and where they are. And hopefully in the future, we can also think of expanding it. So, as some of you may remember, our elections campaign in 2024 was centered around patient involvement. We had a manifesto towards a truly participatory, democratic, and impactful involvement of patient organizations. And that manifesto outlined 10 fundamental principles for patient involvement and for systematic patient involvement. So the idea here with the barometer was to kind of look at those areas broadly. I think we reduced them to 8 in the end, and understand across those areas how are patient organizations involved, how are our members contributing to those discussions. And we're spanning quite a lot of grounds, from HTA, regulatory bodies, as well, health policy more generally. Next slide, please. So moving on to the first, so for today's discussion, really we're going to focus on 3 main aspects because we don't have a lot of time. So the first aspect is really about the institutional framework, and I want to echo what Marco Coreniak said earlier in the first plenary. If you have a law, you have more opportunities to actually make it happen in practice, and that's precisely the objective here, is to ensure and to assess to what extent patient involvement is institutionalized at national level, if there are policy guidelines, if there are laws really that mandate patient organization involvement. So in terms of the results, what we found is that there is some formal basis, either a law or policy guidelines for patient organization involvement in about half of the countries or regions covered. But we still have about a bit more than a quarter that say that there is no framework at all. And you can see here on the slides which countries there are. Another sign of the incompleteness, really, of the framework at the moment is that for those who say that there is a framework in place, it's not necessarily well implemented. So only 5, I believe, of those that have a framework in place said that it is well implemented. And these are the Netherlands, France, Finland, Romania, and Scotland. What we found also when we linked those results about the existence of an institutional framework with the ability of the organizations to actually influence is that actually that institutional framework does make a difference, really. And those organizations that have a framework in place often appear to have a slightly stronger influence on national health policies. They're also generally more likely to report having a decision-making power or collaborative, at least a collaborative role in the health system, and they're also potentially engaged earlier in the process as well. So I will turn first to Charlotte to really give you a concrete example, of what it means in practice. So Charlotte, if you can tell us a little bit, France is one, I think, of the best practice countries, really.
Don't say that.
Still. So if you can tell us more about the institutional framework in France and how you operate, how France also interacts with the government.
All Europeans already hate us, so if you insist on that, you will make my case even worse. So what happened in France, you certainly know that France is a very centralized, institutionalized country, and we love laws. And so, and for good and for bad. And in this case, it was actually for good. We had the first law on health democracy, that's the way we call it, in 2002. We had a rather well-known health minister at that time called Kouchner, and so the law has his name. And actually, this law was interesting because it institutionalized at the same time patients' rights, like access to healthcare records or informed consent, and the collective participation in health policy making. So both were enshrined in the law at the same time. So what happened at that time is that it institutionalized what is called the healthcare users representatives, because we represent healthcare users, not only patients, because of this idea of universalism in France. Also, the idea was that all citizens who have a relationship with the healthcare system because they have access to healthcare system, but also social system. It's broader, so elderly people, disabled people, etc., needed to be represented. So what happened is that it's legalized a system where organizations are accredited by the state, so by the Ministry of Health, or at the regional level, according to whether they have a national coverage or only a regional coverage. So there is no definition of patient organization in the law. There is no real definition of healthcare users organization either, but there are several criteria that you need to meet in order to be able to be accredited. And obviously the first one is to have an effective activity in favor of healthcare users and patients, financial transparency and independence. So we have about over 150 organizations accredited at national level and about 300 accredited at regional level. And what is interesting is that healthcare users are represented at all levels of the healthcare system, not in all policy-making body, but at all levels, from the hospital level, where there is a healthcare users commission, where patients can complain when they had issues, either medical ones or administrative ones, during their hospital stay, up to the National Health Insurance Fund, where patients are also represented in the board. And they are also represented at regional level in the regional health conferences. So one of the key roles of France Asso Santé, which was also created by another law in 2016, is to train those healthcare users representatives. So they need to train and to support them. And obviously another role of France Asso Santé is to collectively represent users and also to contribute with patient views to the development of the health policy and the health policy making. There are some limits to the system, obviously, because nothing is perfect. And obviously there is no obligation, legal obligation, to consult France Asso Santé or the member organization. We have about 100 member organizations. It works usually rather well, so there is a rather fluid relationship with institutions, but obviously sometimes we're not consulted. We're consulted at a very late stage, so it's not completely perfect. And there are some bodies in which we have no representation at all, and especially where prices of medicine are negotiated. That's something we've been claiming for years, and it didn't happen yet. But we are represented in the HTA body, and that's very important because we have 2 voting rights, and we are at the same level as clinicians, methodologists, and so it gives us an important leverage beyond the fact that patient organization can also contribute with written contribution to the evaluation of medicines. And the last limit is that not all accredited organizations are part of France Asso Santé, and not all patients' organizations are accredited, obviously, which means that institutions, they like to have just, one interlocutor, and it means that some organizations as cut from the discussion, and so that's an issue.
Thank you. It's a very comprehensive description of the framework in France and very useful. Hopefully it gives also some food for thought. You mentioned the definition, which is another aspect that we're looking at as well in the barometer. We asked, is there a definition of patient organizations in your law, in your policy, or in the way that you're working at national level? As you know, or may know, as EPF, we are advocating for the inclusion of a definition of patient organization in the pharmaceutical legislation. We are using usually the EMA definition, which we also complement with some additional criteria related to transparency, legitimacy, democracy, and representativeness. Across Europe, there are only 4 countries where there is an official definition, and one of them is Czechia. So I'll turn to Robert here, because one of the interesting things about this definition it was also developed in collaboration with patient organizations. So can you tell us more about this process and also how it changes maybe the way that you work with the government?
Absolutely. So the Czech definition.
And this is Robert Hezak, who is our National Coalition representative from Czechia.
I'll give you this one. Yeah, this one works.
Thank you. So the Czech definition is only 3 years old. It's from 2022. However, the whole process of drafting is started much earlier. It's basically a byproduct of another patient-driven initiative. My colleagues from the Czech Rare Disease Association, they were fighting for a new access to drugs through a specific HTA process, which would include also patient's voice. So eventually they succeeded to co-draft with the ministry a new procedure, which would state that patient organizations are invited or are part of the HTA process for inclusion of orphan drugs into the system. But if you do that, and if you include the words patient organization, you need to define what is a patient organization. So based on this initiative, we started discussing with the ministry, how do we define patient organization? We used a similar concept which Claudia already mentioned. So it was the EMA definition, the European Medicine Agency definition, which is now included in the law. And then there is a more sort of detailed list of requirements. If you want to end up on the ministry list and be registered as a patient organization for all the possible administrative procedures, be it HTA, be it member of advisory board of the ministry, or be it recently a part of the committee which can comment on new legislation, you need to be registered with the ministry on that list. So it's a general definition, and then there are some sort of concrete list of criteria, such as you need to publish your annual accounts, you need to show that the patients are actually at the management board of the organizations, and if you do that, then you are eligible. Our next step, our next hope is actually to be part of the intra-ministerial commenting procedure. So if there's a new law coming from other ministries, we are also sort of compulsory included on that list, and we can actually provide our advice on legislation coming, for example, from Ministry of Social Affairs.
Thank you. So if we can move on to the next slide. So the next question, we saw about the institutional framework and what is there in order to make structural involvement of patient organizations possible. Our next focus is really on how are patient organizations involved. So here, on a positive note, no organization in the countries and the regions surveyed responded that they are not involved at all in policy processes, which is good. We still live in democracies for now. Almost all patient organizations responded that they're involved in advisory committees, in expert and working groups, and consulted generally as part of targeted stakeholder consultations. Only one organization, and that's Malta, and perhaps we can hear from our Maltese coalition a bit later, responded that they're consulted very rarely, once a year or less, and also in Bulgaria we had some conflicting input. So what does it mean, really? This could challenge the assumption, that consulting patient organizations is just a tick-the-box exercise. At the same time, we know that whether, of course, patient organizations can be consulted, but whether their input is actually taken into account is obviously a different question. So only 4 organizations surveyed felt that they were truly directly involved part of the decision-making process at national level and part of the decision-making process on policies that affected their communities. I want to turn to Pedro Carrascal, who's from our Spanish member. If you can talk a little bit about your experience, as in Spain and the new law that will come into place, and how perhaps it will change also your ability to influence policies and perhaps create a bit of a different framework for you and for other organizations.
Yeah. Thank you very much. So this is a good news, an update, because on the slide you have seen before, Spain was on the right part of the chart. Things has been moving this year. We have been pushing the government, and is more active in the patient engagement. So the Ministry of Health announced on summer a new future law that is starting to be transmitted on the Parliament next year. And this is very important for us because it's starting to structure the participation, the patient engagement for first time in the history. Until now, we didn't have the definition of patient organization in the health system, and we are using also the EMA definition and EPF point of view. So this is part of what is covered in the law. This is not only the definition, but also the legitimacy of patient organization inside of the health ecosystems, recognizing as new actors, of course, with the obligation of engaging in the decisions and taking part in the governance of the health system. But not only this, but also promoting and training patient organization with different kind of measures on that. This is only part, this is only the top of the cake, because we are also facing new regulation. For example, the new medicines law is also is on the table, and this is covering also funding for patient organization, and also the Spanish HTA is also talking about training and patient organization definition, engagement. So in the last year, 1 year, 2 years, we have been changing the future legislation for patient organization, and this is the future for the patient organization in Spain. Thank you.
Great. Thank you. If you can move on to the next slide. So, lack of resources. Perhaps before we move to the lack of resources, which is very much linked also to what Pedro was saying, I just want to make a point on transparency, which is also a question that we addressed in the barometer. And transparency, the existence really of a framework for selection, of patient organizations based on transparent and fair criteria. And for example, we asked about the existence of conflict of interest policies and of transparency registers. At the moment, only 2 countries have transparency registers, or the organization of regular public calls for applications. And that's only in 4 countries, according to our results. So transparency is still a black spot, and we wanted to link it really to the institutional framework, because in those countries where there is a strong institutional framework in place, there is usually more transparency and more structural involvement of patient organizations. And one trend that also comes in our findings is the emergence of patient experts, increasing use of patient experts. And this is something as patient organizations that we need to think about, and how do we position ourselves as representing communities versus, the increased reliance from a policy perspective on patient experts. So perhaps also some food for thought for our speakers. So moving on to the lack of resources, which indeed was mentioned as the number 1 barrier to patient involvement and to patient organization involvement across the board. Other issues that were mentioned were the lack of access to decision-making processes, the unequal representation of certain groups, the fragmentation of health system as well, the difficulty to navigate healthcare systems, as well as low political recognition of patient organizations. So there are broad barriers, but really the one thing that came first was really the lack of funding and the lack of resources. So we asked about the existence of government grants, which still are the most common source of funding or public funding. It accounts for relatively partial parts of the budgets of the patient organizations, between 25 and 50% for most respondents, but there is still half of respondents that still experience minimal or no public support. So on that also quite a lot of progress that needs to be made. If we move on to the next slide, because all of this, and this is about the government grants, so I think we can move on. So all of this really is to link it to the impact. So how do we link those aspects of involvement, the existence of an institutionalized framework, the existence of definitions, of a basis really for involvement, to how can patient organizations really influence and really impact the healthcare systems at national level. And we feel, that a lot of organizations actually feel that they do have an impact, so a moderate, strong impact for 17 of them. A moderate impact for 17 of them and strong impact for 3 of them. So in that sense, it's a relatively positive thing, but of course, we can still, there's still progress that can be made. So I'll turn to Nikos as well. Perhaps speaking of impacts, if you can tell us a little bit more as patient organization, what you've achieved in Greece and how you bring value to the healthcare system.
So now you make me wonder whether we were one of the 3 who suggested that we had a strong influence, because always the type of influence that you have is much less than you wish, and much less than what you expect. The Greek Patient Association was created 2 months before COVID arrived. And in that sense, we didn't have an opportunity to ever meet, subsequent of our elections. But also it was a time where health became a very important issue. And indeed, the organization immediately was part of this effort, to make campaigns of information, battle disinformation. And when the vaccine came, it was clear that by that time the state needed another actor to be speaking to the citizens or to the people with underlying conditions, because they were the ones who also was critical to get vaccinated fast. And the Greek Patient Association also created a campaign, which was designed by us, and this was retweeted by the Prime Minister. So a little time later, by December of 2021, we were invited to the, to the President's palace, to the Prime Minister's office. And there what we proposed was actually to follow the Cyprus example, where by legislation there was an institutional recognition of the role of patient organizations. And indeed, he instructed to follow through this. And in May 2022, such a law passed, giving a recognition to the Greek Patient Association. Indeed, it just happened that I saw the Prime Minister two months later and thanked him for that. And I said, by the way, we have now, we expect some resources. And I thought that would be the end of the discussion. And he says, how much? I was taken aback, and I said, okay, well, this is what we consider a reasonable scale up of our turnover. But it took a couple of years. Only 2 months ago was the legislation passed, which foresees the funding of the organization. One of the most important things that I think we achieved was and then of course the main objective that this umbrella organization had was the participation in the design, in the implementation, and the evaluation of health policy and programs. And in one instance where this happened recently was that we said that it has to be the users of the health services, the one who would evaluate the health services. You can imagine that governments are reasonably agitated if you ask the citizens or the healthcare recipients to tell their opinion, but we advocated for that, and indeed in the summer, this survey that is given to everybody who has entered the hospital and has come out of the hospital. So there's a little bit of a bias. You had to be alive to answer the questionnaire. But actually the result was surprisingly positive. 60–70% were very happy with the services. And at the same time, the political discourse was that the health system in Greece collapses, that nobody has what they need. So it was a little bit of a gamble, and that is why we were surprised that they already reported the data within 3 months, even before the end of the year. So that was an example where the voice of the users was given an option. And I mean, you can imagine that people were complaining about the toilets, about the food, some of these things, or some waiting lines, but for many of the important things, that was a very positive outcome. So it's always an effort, but I think we have made a lot of steps towards the direction, and they were met by activities from the state. Perhaps being in a small country, it's much easier to reach the highest level of the ministry or even the Prime Minister.
Stefan, can I turn to you as the only member state representative here? What's your feedback on what you've heard?
Thanks. Well, I was wondering if that is a good or not a good sign. Mostly, maybe not a good sign, being the only person from a policy perspective, also from a member state view, because I think in the end it's about, and I heard a lot about that, about silos and the need to break up silos, and this is something that is through my entire career is kind of part of this development, to understand better and better the different languages that we talk. And it's different languages between academia and policymaking. It's different languages that we see more and more between finance and health and those other sectors. I don't say that health is so special, but maybe it's a bit special in that regard. And definitely it's also different languages that we talk between patient organizations sometimes and policymaking. So I think, but if we all say in our own bubbles that we need to break up these silos, well, it will not change, right? This is why I also think the making it happen is the thing to do. It is clear that given the health sector, that there is a demand for coordinated action by all concerned, by governments, by health and other social economic sectors, by non-governmental and voluntary organizations, etc. So that was a citation from the Ottawa Charter. Some of you may know it. It's pretty much from the year of my birth. And my question is really, and allow me to be a bit more provocative maybe here, is it really the progress that we want to see jointly, and is it happening? And again, I have this feeling, to be honest, that it's that somehow from all sides we are not very successful in breaking up those silos. And it's absolutely necessary and good to collect those best practices, but also there I sense a bit of an issue that we experience a lot in health systems, particularly in fragmented system. I would challenge that it's easier with small countries, because if it's a fragmented country like Austria, the size is not helping alone, because then still there are so many different actors and ministers, etc., responsible, right? So the question is, why don't we succeed in scaling up? Yeah, and I think this is also something that you showed, that it's not I would state that it's not the number of pilot projects and best practices that we need. It's really this structured approach, how to work better together and achieve better outcomes in doing so. And in the end, it's quite easy. I mean, policy making is very simple. It's about making decisions, right, and balancing. And obviously that is much easier and nicer to do in times where you have more money and where then the resources that you also addressed in the previous slide is not so much as of an issue, but it's always about balancing trade-offs. And that is also why we see that health as a priority is not that relevant in the public discussions anymore, because policy making is about making trade-offs and making decisions. And I think the worst policy making is not making decisions, because in the end, obviously, everything moves on. So also given the experience that we had in Austria, I totally agree with the strategic structured approach that we need. We also see very good examples. One was also and it often happens in the area of medicines, and that was also a recent example where in Austria we were quite successful in having the patient advocacy group, which is obviously not per se the patient organizations, but also there stopping to have this competition between the legally defined patient advocacy and the patient organizations, but teaming them up, giving them more responsibility. And for me, that would be really the question: how can we step up in also taking joint responsibility and not only joint views? Because in the end, and I don't know if time allows, but what I didn't hear today, really, it was a lot about the EU budget, and I sense the urgency and I share the urgency. But what I really see as one of the areas is the perspective of public budgets, not on the EU level alone, but also in all our member states in the end. And there, I think it really is a question, again, on how to use those scarce resources most effectively, and it cannot follow a pattern where the loudest voice defines the direction. It cannot be a simple top-down approach. I think we all agree on that. But it needs more responsibility then on all sides, and I think that is something that in policy making we also require and demand for, also from patient organizations, to allow a joint responsibility there. Talk about the use for small hospitals that we have in many countries, where there is a discussion, where do we really want to spend our resources, and clearly throwing more money at problems is not an option anymore, if it ever was.
Thank you. Nikos, you want to react?
Yes, the minister who was present at the meeting with the Prime Minister and who actually oversaw this first recognition of our role was a minister who, one of his first things was to take out from the board of directors of the payers organization the representation of patients. He was very suspicious of non-governmental organizations and patient organizations. And one of the things that he said towards the end of his term was that I was always very worrisome that the patients will have maximalistic requests. And that's why he didn't want them in the payers' board of directors. And what he found out is that we, the patients, are the ones who are most interested in the resilience and sustainability of the health system. We are the ones, we are the first, and we are the, let's say, partners together with the state. Everybody else has demands of how to milk the system. But we wanted to be there, to be resilient and to be sustainable. So he changed his mind. And as you said, there are scarce resources, and we, the citizens, are the ones who must participate in that.
I really much want to support what you've been saying, Nikos, because so what happened in France, so we are all in the same situation about budget constraints. So, what has been proposed in the latest law to fund the healthcare system, which is voted every year at this present time, voted, discussed, and maybe voted, is that, so what the Ministry of Health has tried to do is to cut where it was easy. And cutting what is easy is increasing co-payments, because it makes a difference the day after. So you've got it, you've got your accounts, and that's clear. And obviously, it does not increase trust, and it is not a good basis for cooperation. And I completely agree on the fact that patients, for instance, taking just one topic, price of medicine, since we were mentioning it, are very much interested in sustainability, and they don't want medicines at any price. So I believe that responsibility goes together with trust, but we need to work long term, because we know that lots of money which is not well used in the healthcare system. And we need to try to make sure that we make the best possible use of our resources. And patients and healthcare users are those who have the greatest interest in keeping the system.
And maybe to add to that, because I really see this is the one area we need to team up as much as possible and much more than on the other areas, because the concern that I see, there is a quiet transformation happening at the moment. And the quiet transformation in health systems is, in the end, you have reports by the OECD, by others, showing that there is a trend again towards a financialization within the healthcare system. So not privatization and not dogmatic discussions about who should be the organizers, etc., but more really this topic of financialization, where actually you embed health services within an investment, following investment logics. And what we see that this is quite an appealing option in times where you have patient satisfaction, often not as bad as we assume it should be, but many times, I mean, there are discussions of waiting times, etc., and we are not able to respond to that properly. And the thing is, it goes so quickly that you go into a development with financialization, changing the healthcare system away from a solidarity-based healthcare system, and to revert that is so difficult. And I think if we do not manage to protect the strong European welfare states based on solidarity, being quite innovative, being quite resistant as we saw, and have this development, then I think this will be the biggest threat to patients in particular, because if you lose this solidarity-based approach, then we really need to worry about universal health coverage, and then typically it hits the most vulnerable ones. So that is why I think in the end, and maybe that is the question, it's not longer how do we involve and include civil society being a bit broader than patients, but really how to make it a mature and accountable partner in decisions that inevitably involve losers, because that is the question nowadays. There are losers in decisions, obviously, and the question is, it cannot follow a pattern where it's the loudest voice. It really needs to be evidence-based. It needs to be looking at really this burden of disease. And there, I think we need to do it hand in hand, particularly in times where you have also populist voices that actually promise that there is no need. There is no need for losers, right? There are possibilities to have everyone happy and to save every hospital, to save medical services for everyone in every region. And I think there we need to really come together and have these discussions on values and on ethical decisions that are really difficult.
So yes, if I can say, the dream of the Greek Patient Association is to educate citizens well enough so that when a politician says that we're going to make a hospital next to you, is to vote them out. Because this is what has happened. The landscape, the map for health and where the hospitals are, everything needs to change. I mean, Greece has mountains, islands, a lot of problems, but things were designed in an era before we had a huge road, which now it's faster to go to a different city than it is to go in Athens from one hospital to the other. So there's so much populism, and the citizens must be the most savvy, not the least.
If I can just comment on what you said, I think it's very important. Indeed, you want professional organizations that can share the responsibility and that can act constructively in this. At the same time, we are facing existential threats as well at the moment as patient organizations and as civil society. So I think you have to balance, this need. It's always there's more that is being asked from us, while at the same time, we don't have the resources in order to provide that professional input, So perhaps just a caveat to what you mentioned.
Absolutely. This is also what we tackled now in also an approach that was shared already with capacity building, where in areas, particularly HTA medicines, because obviously it's so complex that it really is necessary. We had resources in our Public Health Institute, particularly working with patient organizations and the patient advocates. And in the end, it's really, I think we need to go beyond this question of co-designing and co-defending the values that our health systems actually protect, right? And this is maybe this more strategic approach that would be, I think, absolutely necessary and important because we will have some rough years ahead of us, definitely.
I see Borislava and Ruth that are telling me to conclude. So I'm sorry, Charlotte.
Just wanted to say a few words about money.
One sentence, because it's an important topic.
Yeah, just wanted to say that the law in 2016, when it established France Asso Santé, it also provided for funding of the operation of the organization, all activities, and also for compensation of healthcare users representative who are part of all these decision-making bodies. So I believe it's also part of the solution.
Thank you very much. Thank you very much to our panelists for a great discussion. What's next? We will publish the barometer next year, so stay tuned. There will be much more in this. And okay, I'm done. Thank you.
Claudia's collecting the plants at this point. All right, we have to be a bit more fast now. First of all, again, thank you very much to our speakers. It's great to learn about the level of patient involvement in health policy and identify the barriers and good practice moving forward. And we look forward to hearing more about the barometer results, so stay tuned with our policy team. So looking forward to that, to hear more. Okay. Here we are at the end of the first day of the EPF Congress on shaping the future of healthcare and preparedness for health systems resilience. It was a very successful day. I think we had quite a lot of fruitful conversations. Of course, there's a lot more to talk about, but if we focus on all of these topics, we're going to be here, I think, for days. So unfortunately, this is all the time we have for today.
So yeah, very grateful to have you all in the room despite the strikes and everything. Really appreciate the efforts you've made, perhaps extra efforts to be here. So thank you so much. We have some brilliant minds in the room. Thank you for all the inspiring discussions. We've had the opportunity today to talk about access to healthcare systems, AMR, EU budgeting for a sustainable future, and so much more. And speaking of funding, Bori and I are available for weddings, birthdays, and children's parties.
Keep in mind.
Anything for some extra funding. But jokes aside, we all know that funding is hard to come by right now. So if you are able to, especially with the lack of operating grants available at the moment, if you are able to support patient organizations, please do so as best as you can. The patient voice should not be silenced. So please do support as best you can.
Yes. All right. Now that we have successfully analyzed the situation of today in all of our workshops and in all of our plenaries, I think it's very clear what the problems are, what our complaints are as a patient society, and we're very much looking forward to tomorrow where we're going to talk about solutions. So let's not only complain, but let's also discuss what we can do about it, actually.
So tomorrow we'll start at 8 for the registrations and for coffee, but the agenda will start at 9 a.m. back here in the ballroom. Those of you who are staying at the hotel, breakfast is available from 6:30 a.m.
And some more reminders, we would like to welcome all of you in the lobby just outside for a networking cocktail from 6, so in just a few minutes. Then at 7:30 we have a registered only dinner. Again, you can check your badge to see if you're registered to attend the dinner. And then here, it's going to be here in the ballroom, actually, the dinner. If you aren't sure, again, and you're not sure also in your badge, you can reach out to an EPF staff member or Isabella. You already know Isabella, so you're easily going to find her. And for those of you that are leaving tomorrow, please don't forget to check out of your hotel rooms by 12 p.m. You're welcome to leave your suitcases at the reception, but the checkout time is final. Yeah.
And I think there was a reminder to also bring your badge again tomorrow. Wear your badge again tomorrow as well. So before we head to the cocktail, we'd love to capture this moment with you. So after, when Bori and I have finished talking, you'll be glad to hear we do stop talking at some point.
Sometimes.
You're welcome to join us on the stage for a family photo.
So please, let's all gather here up on the stage and just below the stage for a photo. And just to share with you, this is a bit of a challenge, but we would need to empty the room in 5 minutes. I'm not sure if you can do it, but I believe in you. So please, after the picture, let's go outside. And there's the photo booth outside also.
So just a final thank you to everyone for coming today, to all the contributors, to the EPF staff for making this event possible, to our members and also to our sponsors. So thank you very much, everyone.
They found it.
So please come and join us on the stage.